Welcome back to the Neuroanatomy StudyCast. I'm your host, Masi. In episode 2, we navigated the maze of the brachial plexus, covering roots, trunks, cords, branches, and their clinical implications. Today, in episode 3, we're taking it a step further: how to translate the anatomical knowledge into clinical practice using S.O.A.P notes. That's right, we're connecting neuroanatomy straight to the patient. Evaluation and documentation. By the end of this episode, you'll know how to write S.O.A.P notes that reflect your neuro findings and help guide treatment. Stay tuned for segment 1. Segment 1: Why S.O.A.P matters in neuropractice. If you remember the brachial plexus, you know how many moving parts there are: roots, trunks, divisions, cords, branches. A single lesion can affect sensation, motor function, or reflexes. S.O.A.P notes let us capture these clinical details systematically. Subjective: what the patient reports, tingling, weakness, numbness. Objective: what you find on the exam, reflexes, muscle strength, sensory deficits. Assessment: connect the dots between subjective and objective findings, which nerve root or cord is affected. Plan: define interventions, referrals, or exercises, all grounded in anatomy. It's your bridge from memorizing diagrams to treating real patients. Stay tuned for segment 2. All right, we're back with segment 2: subjective, listening for neural clues. The subjective section captures the patient's own experience. For brachial plexus injuries, ask about numbness in specific fingers, weakness in certain muscle groups, difficulty with fine motor tasks. Patient reports an ability to flex fourth and fifth fingers on the left hand, tingling in the medical forearm. Symptoms started after a fall. From this, you might suspect ulnar nerve involvement from the medial cord. That's an example. Segment 3: objective, mapping anatomy to findings. Motor tests: weak elbow flexion, check musculocutaneous nerve, wrist drop, check radial nerve. Sensory tests: pinprick or light touch deficits, follow dermatomes and cutaneous nerves. Reflexes: biceps reflex, triceps reflex, finger flexor reflex correlate to nerve roots. And special tests: Tinel's test, Balin's, or shoulders abduction tests for nerve compression. Example: weak flexion at the elbow, musculocutaneous nerve. Sensory loss over medial forearm, medial antebrachial cutaneous, and finger flexion deficit ulnar nerve. Every finding links directly to a branch, cord, or trunk from our episode 2 brachial plexus map. Stay tuned for segment 4. Segment 4, Assessment, Diagnosing the Neuroanatomy in Mind. Your assessment should synthesize subjective and objective data. Use anatomical knowledge to localize the lesion. Example: left medial cord lesion, ulnar nerve weakness. Upper trunk lesion, C5, C6, affecting shoulder abduction and elbow flexion. Modifiers like severity of VAS scores help quantify systems. This section is where anatomy becomes clinical reasoning. Stay tuned for section 5, the plan. Section 5, the plan. From anatomy to action. Finally, the plan in neuro focused SOAP notes. You might include adjustments targeting cervical or thoracic levels, strengthening exercises for affected muscles, referral for EMG or imaging if needed. Follow up to recess function. Example: therapy, elbow flexion exercises 3 times a day. Next visit, 1 week to monitor ulnar nerve recovery. Avoid compression of medial cord during daily activity. Notice how each plan item is tied directly to anatomy, from cord to terminal branch. Stay tuned for segment 6, takeaways. All right, this is our segment 6, takeaways from this podcast. Here's what to remember: SOAP, SOAP notes help translate your anatomy knowledge into clinical action. The brachial plexus isn't just for exams, it guides real patient care. Structured documentation ensures nothing is missed. Symptoms, findings, diagnosis, and plan all tied to neuroanatomy. In our next episode, we'll dive into spinal cord tracts and lesion patterns, again, connecting anatomy straight to SOAP documentation. And again, this is your host, Masi. I'm signing out for today, but I'll be back again for our next conversation.